Hello, everyone. Hopefully you can all hear me okay. But if there's any issues in between, please just let us know in the chat box below. So my name is Marina. I'm the new webinar coordinator for Evidence Synthesis Ireland. We're delighted to welcome you all today to the ESI webinar series. So just by way of a brief introduction, some of you may already know, but just in case for the newcomers, ESI, Evidence Synthesis Ireland, which includes Cochrane Ireland, is an all-Ireland initiative funded by the Health Research Board and the Research and Development Division of the Public Health Agency in Northern Ireland. Our aim is to build evidence, synthesis knowledge, awareness and capacity on the island of Ireland. We have a number of key activities for achieving that aim, and one of them is a monthly webinar on an evidence synthesis topic. So our presenter for today, which we're absolutely thrilled to have, is Professor Soo Downe. So Sue is on the line here with us today, and I might just briefly introduce her before I then hand over, and hopefully in the meantime we'll have a couple more people join us in the meantime. So Sue worked as a clinical midwife between 1985 and 2000. In 2001, she joined the University of Central Lancashire, sorry, UCLan, where she is now a Professor of Midwifery Studies. Her main research focus is the nature of and cultures around normal birth, and she is a Cochrane Effective Practice and Organization of Care EPOC editor. She's been a co-author on papers in 3 Lancet Series, Midwifery, Stillbirth, and Reducing Caesarean Section. She has published over 150 peer-reviewed papers and has undertaken research using a wide range of qualitative and quantitative methods. With the team at UCLan, she has undertaken qualitative evidence synthesis to inform and frame a range of World Health Organization (WHO) guidelines related to maternity care. She's also been a part of a series of papers on undertaking QES reviews. So in this webinar, which we're very much looking forward to, Sue will describe the synergistic development of qualitative evidence synthesis techniques and WHO maternity care guidelines as an example of how iterative methodological innovation can make a difference to the framing of what counts in practice. It will also cover the further use of the results from QES reviews and implementation of guidelines into practice in a range of countries and settings. So we'll have time for questions and answers at the end, but please do feel free to type your questions into the Q&A box below, and we'll gather them up and we'll go through them at the end. But in the meantime, Sue, if it's okay, I'll hand over to you, and in your own time, take it away.
Thank you very much, and thank you to everybody for putting the time in to be online. And I definitely, I know that there's probably people with a range of experience, both in reviews in general and qualitative research and qualitative systematic reviewing. So I'm sure there are people on the line who might have more experience than me, and all I'm doing now is providing a particular perspective. And the reason that this picture is up, which I'm sure most of you have seen numerous times, but I have to say I've seen it hundreds of times, but I still have to work at seeing both faces in the picture, both the young woman and the old woman. And if you can't see those 2 faces, then when it gets to the chat, we can come back to it and have a look at it. But the reason for that picture is just to say that this is one perspective, as I've just said. There are other perspectives. There are many different disciplines or many different approaches to qualitative research. There are many different approaches to reviewing and so on. So one of the things we can discuss maybe at the end is what other people may be doing as well. But I'm also going to be providing some of the kind of basics, if you like, just because I know there's some people online who may or may not have come across some of these techniques before. So bear with me, those of you who've done loads of these and for whom this is second nature, and also for those for whom it's a bit new. I'm sorry if some of the stuff is, I don't explain as well as I might do some of the stuff, so we can unpick that at the end. So I'm hoping that my controls are going to be working now. There we are. So I want to thank these people. You'll notice that this presentation has a range of different backgrounds. That's because it's come from a range of different sources, and I wasn't always good at taking the background off to make it kind of coherent. But actually the advantage of that is that when you see this slide with the swirly lines, it's been produced by Tess Lowry, who works regularly with WHO on this work, and she had some great input into some of the slides. And some of them are from Uzga Tunkalp, who was one of the kind of, in my sense, midwives of this work. And then Kenny is the person, Kenny and Carol and others at UCLan that we've worked with various different of these guidelines, and many others have also contributed. So I want to start off by, I don't know if you can see because the little video is partly across. I don't know if me moving it makes any difference to you, but anyway, this notion of standardized care. So I've just picked this particular paper. It could be any paper. It's not a critique of these authors necessarily, but this notion that guidelines are about the same thing for everybody. And I know that's not quite what this paper is saying, but they tend to be translated that way, that once you have a guideline, that's it. You know, it is reified into a protocol and there is no variation, unless the guideline says there should be variation. So, oops, oh, sometimes this is working and sometimes it isn't in terms of my, there we are. So I want to just kind of, I suppose, raise a question, and others have done this as well. I know Andrew, I came across a paper of Andrew Booth, I don't know if he's online now, from 2001, raising this critique. So, you know, this has been raised for a large number of years, and certainly before we even got engaged with it. But I want to take a particular example. So this is around labour pain, obviously particularly relevant to, you know, my field. So the Cochrane review on epidurals says epidurals are an incredibly effective way of reducing labour pain. But of course, that's not the only phenomena. One may imagine that reducing labour pain is an end in itself and it's a good thing and so on and so forth. But what qualitative evidence shows us is actually something else may be going on here, and not just in the labour pain field, but I'm just using this as an example, as I say. So this is a couple of studies that were undertaken by Ulla Waldenstrom in Scandinavia. And her team looked at the recall of intense pain at 2 months and 1 year. So women that had the same pain scores 2 months after birth, if they had had an epidural, they tended to remember that pain much more intensely at 1 year postnatal. So all things being equal, those women who had an epidural remembered their pain as a much more intense phenomena when they were asked 2 years later than those who did not have an epidural. And the authors actually thought this might be to do with where memory for labour pain gets stored in the brain. It may also be something to do with the fact that, you know, if you have an epidural at the moment of most intense pain, then it kind of gets frozen in your brain. Whereas if you have that same intense pain, but you go on to, you know, labour, then labour without an epidural, then you tend to increase endorphins, and those endorphins may actually mitigate against the memory of labour pain. We don't know. The point is that labour pain is not in and of itself a stable and static phenomenon, and this is one of the things that qualitative research begins to throw up. What else is there in these phenomena that look like they're stable and static, that tend to get measured in effectiveness reviews? And the other aspect that our team have been working with for some time is this notion of salutogenesis, which is quite well known in Europe, interestingly enough, particularly in Northern Europe, but hasn't been until quite recently in the UK and in other countries like the USA, even though actually Antonovsky, who's the guy that came up with all this, is actually a USA medical, or was a USA medical sociologist. But the idea really was this, that we tend to think in pathology terms. We tend to measure negative outcomes. That's the translation of that for what we're talking about now. We don't often think about what makes things go well, the positive side of the health continuum, when we look at evidence reviews for effectiveness. So that was another piece that came into this puzzle when we were beginning to work with WHO, or before we began to work with WHO. So this is the question that Antonovsky asks. What about not only, I mean, he doesn't say you shouldn't think about risk, but he says there's more than just risk in the health continuum. What about when things go well? And of course, this is, you know, if you look at Sackett's definition of evidence-based medicine, this is there. So basically in evidence-based medicine, what he says is this is a combination of three things. But the evidence, of course, and that can be quant or qual, the evidence, clinical expertise, and patient value. So it's that combination of expertise, value, and evidence, not just the evidence itself, which actually turns out, creates this alliance and these optimal outcomes. And so he talks about quality, clinical outcomes and quality of life, which is where this other side of the mix comes in, maybe. I like this Pettigrew and Roberts paper. If you haven't seen it, it's worth digging it up, even though it's really old. But they've just raised this question, which is a fairly common sense question, but tends to get lost sometimes in the general EBM debate about, you know, the question that you ask or the study that you include should answer the question that you're wanting to, the question and the study design should go together effectively. So there are some questions for which quantitative evidence cannot provide an answer, and therefore you need the qualitative evidence to come into play. However, there is a problem with this, because, you know, for those of you who are qualitative researchers for whom that's your philosophical kind of orientation, there is this line, this epistemological nature of knowledge, or even ontological nature of reality, if you like, view at the purest end, that qualitative evidence cannot be integrated, that it's actually in and of itself a thing, a phenomena that can't actually be reified into anything that's more integrated or summarized. And this is expressed in this quote from Sandalowski. But in contrast, there is this notion from others that if we do say, well, qualitative evidence is, from a purist perspective, phenomenological evidence in and of itself that can't be further integrated, then actually it becomes irrelevant to policy and practice. It's just an interesting thing of itself. Storytelling doesn't really tell us anything much more than that. So there's a long, as many of you will know online, there's an ongoing criticism or critique, not criticism, constructive critique about the interplay between qualitative evidence and guidelines and QES and so on and so forth. And obviously we're part of that. You online are part of that, and we in our team are part of that, and others out there in the big wide world are part of that. And it's quite an interesting place to be, because it's not about using standard guidelines, because we're having to think about this from a philosophical perspective, because the guidelines don't exist, even though they're beginning to exist, and that may or may not be a problem. I mean guidelines for doing this kind of research when I talk about guidelines now. So this is one definition, one well-known definition from Fingold about what metasynthesis is. An attempt to create an overarching synoptic claim on the basis of various analytic and synthetic strategies. They may not be useful. I've actually used the term knitting smoke here, which actually I got from Harry Potter, one of the Harry Potters, because it feels a bit like that when you're doing this, that how things fit together is constantly slipping in and out of focus, which is another quote from I think Thorne, about how you do this kind of work. And metaethnography is the place where most people tend to start with this. This is a useful little book. It's easy to read, very well worth getting hold of. A lot of people say they're doing metaethnography, but have never read this book. And I think it's very important that if you say you're doing it, you read it. Metaethnography in itself, and again, I'm going to come back to that, isn't something that can be done from a purist perspective, I don't think, to inform guidelines. But it's a basis, it's a kind of principled basis for doing so. And our first metasynthesis we published in 2007, which was around expertise in maternity care. And the basic idea is you take you find your studies, you take the initial study, you look at the key themes, and then you build a kind of theoretical analysis on the studies as they come into the mix, as you bring them into the mix. And you look for both refutational and reciprocal and refutational data. So you're basically saying, are these studies that are coming in now saying the same as the first study, or are they saying something different? And then your theoretical analysis, your line of argument, synthesis as they call it, has to take into account all of those data, a bit like a grounded theory study would do. And what I noticed certainly in the early days is that people did a lot of the reciprocal analysis. Do these studies say the same thing, but far less of the refutational? What are they saying that's different? But that is becoming more mainstream now, particularly as people are beginning to integrate reflexive accounting properly into their analysis. So it's an evolving field, metaethnography itself. So the direct precursor to us getting involved in WHO was this study, which was undertaken in 2009, and it was a question about why women in high-income countries don't attend antenatal clinics. And having done that particular study, we then did one on lower middle-income country studies, which was published in PLOS Medicine. I think it was one of their first qualitative studies published in PLOS Medicine, which shows that, between, if you like, Andrew writing his piece in 2001 or even before, it was 10 or 11 years before this, and there are other people working at the same time, but it's been at least a decade. It was at least a decade before this began to be taken seriously, and it's been another decade since, until we've got to the point we're at now. So this is a slow moving process, but it's gaining traction rapidly now. So when we published this, and it was picked up by WHO, because we did it quite systematically, unlike many other quality reviews that have been published, in that we actually, for example, logged the studies that we found against the themes that we derived. So it was very clear to see where the data came from, which isn't always necessarily, wasn't before that always necessarily done. And we found with the data that the reason women didn't use antenatal care, from our data anyway, was because of a disconnect between the way services are designed and what women's underlying philosophical values were around pregnancy and antenatal care. So we found that this assumption in the system is that pregnancy is potentially risky for mother and baby, that it's a positive social state. I'm reading down the first column. Positive social state that's welcomed by the family and the community, and that there's enough resources for women to make a rational economic choice to access ANC. That's the kind of basic way in which ANC is designed, or the assumptions on which it's designed. But actually what we found for women who don't access care in many countries, they thought that pregnancy is a healthy state. Why would you go and be checked up in a hospital if actually you're healthy? What's the point? And then secondly, that actually, and this was a surprise to us, I have to say, because we were all coming from a high income country perspective, that pregnancy can be socially risky in some setups. So not clinically risky, but socially risky. Because, for example, you can get the evil eye put on you if people know you're pregnant, and that can damage you and your baby. So why would you turn up at a hospital with a big sign saying antenatal care and reveal your pregnant state before you need to, if you might end up being socially marginalized or disadvantaged or even damaged as a consequence? And thirdly, and again, this isn't really a surprise, but it was there in the data, that for many women, accessing care means a choice between survival and going to get the care. For example, if it takes you 3 days to get to a clinic and you're leaving the fields for 3 days and they're not being looked after and your crops fail, why are you going to go to the clinic? Unless you can see a real advantage. Or, if in going to the clinic, you might be attacked by wild animals, or the roads are out, or there's no transport, or you might get attacked by, you might get raped, for example, which is, the case in some cases, you're not going to go. So that is why it seems that women didn't access care, not because they didn't want to look after themselves or their babies. So this is the same kind of thing, really. And at the bottom, basically, the point is the consequences of difference between antenatal care assumptions, and the women's experiences. Basically, so the first slide you saw was about not going in the first place. And this second slide is actually about why women didn't come back once they've been there the first time. So again, the assumptions about service delivery, once women actually get to the clinic, is it's affordable, care is affordable when they get there, but actually what women found is they were subject to unexpected costs. So they were asked to pay for, needles or screening tests or bits of paper or whatever it might happen to be at the point of care when they shouldn't really have been. Secondly, that the staff attitude was not necessary. So the assumption in the system is that the staff attitude doesn't matter or is generally positive, but actually many women found that staff attitude was highly relevant and often discriminatory, neglectful or abusive. And thirdly, when women get to care, the assumption in the system is that all the resources they need are there, but actually what women found is that often the resources weren't there. So many women bypass local antenatal care services and go to higher level services because they know if they go to local services, the resources won't be there, or they don't bother in the first place because the resources aren't there. So under these circumstances, women don't go back, even if they go for the first time. And then finally, lack of initial access plus lack of repeat access, we hypothesize, leads to increased maternal and infant morbidity and mortality. I mean, we didn't know that from our data because they're qualitative data, but what we were saying is that theoretically that's likely to happen. And if you don't change your ANC so that it accommodates these different perspectives than the ANC system imagines are out there, then you're going to have a problem. And this is just the same thing, but this is in the paper actually, but in a table. So in parallel to all this, WHO was also beginning to evolve ways of looking at qualitative data. And Simon Lewin and Claire Glenton from the Norwegian Cochrane Centre have been very active in this regard with WHO. And they produced this I think is the first prototype QES that was ever produced by WHO, which was happening again, 2012, 13, 14, 15 was when these things began to rev up. And then the other work that they were involved in, they've been involved in, and again, I'm sure some of those of you on the call will have been, is to develop SERQUAL. So this way of actually assessing the quality, not of the individual studies in a qualitative evidence synthesis, but of the synthesis of the studies. So the findings that emerge from the studies are then assessed against this SERQUAL criteria, which acts like grade criteria for those who do this for quantitative studies. And we can talk about what QES is later if we've got time, if people want to, but it's probably, it needs its own, if it hasn't already had it, it probably needs its own webinar really anyway. And then again, at the same time, there were these notions of quality of care were beginning to come into play in WHO in terms of the health systems, quality of care models that were beginning to come out. So this is one of Özge's, she was a lead for one of these models that are coming out that began to say, this is not just about the provision of care, it's about the experience. And if you start to talk about the experience of care, you have to start bringing in qualitative evidence. You can't really get that very easily from quant studies unless you look at surveys, and even then surveys tend to be based on what researchers think is important, not what service users think is important necessarily. And of course you also have the Joanna Briggs Institute becoming operational over this time, Cochrane Methods, the Qualitative Methods Group, and EPOC. So just going back to WHO in this mix then, before the inauguration of these ways of doing things, this is a kind of very busy diagram of the way that that guidelines were produced. And basically from the top, the PICOs were set up for effectiveness reviews. The outcomes were determined usually by a panel of experts, not usually involving service users, as to what were the important outcomes. Then the review was done of the effectiveness reviews, risk of bias was assessed, and then recommendations were made by the panel. And the panel might say something about whether there was actually any values and preferences that might balance against the effectiveness reviews. But it was only done at that end point, and only ad hoc, and only people happen to know about various things was that kind of evidence brought in up until the integration of QES into WHO's work. So more recently, well, even then, these were the factors that were considered. So benefits and harms, obviously that's from the effectiveness reviews. Resources and cost effectiveness tended to be from what the panel happened to know. Values, acceptability, feasibility, and equity, again, from what the panel happened to know or think. The panel being chosen for their expert knowledge in these areas. And these are the areas specifically, and to some extent, resources and cost effectiveness, where the qualitative evidence is beginning to make inroads. So this is a summary of the qualitative evidence synthesis process as it now is. So first of all, a systematic review. As a normal systematic review, a systematic search, as a normal systematic search would be done. This is to an extent controversial with qualitative evidence, with qualitative researchers, because there is a debate about whether you should find every single study that ever existed, as you would for an effectiveness review, or whether you should just find representative studies. And various people have done various things along those lines, and so have we, in fact. So we have done some reviews where we've looked for every single thing and integrated it into the analysis, and others where there have been so many studies that, and often so many from one country, that they would have unbalanced the analysis. And so in that case, we've done sampling. And again, ongoing debate about how this should or shouldn't be done, but always with an eye to the principles of what is the strength of the evidence, what's the disconfirming data, what's the confirming data, and are we missing anything critical from any particular context, which is where CERQUAL comes in. Because when you look at CERQUAL, it says, are you actually getting a balance between relevant studies, studies from the whole range of populations you're interested in, good quality studies, and studies that are coherent across the piece. So going back to the beginning of this line, so you find the studies, you assess the quality of them, the individual studies in this case, and again, debate about that, how that should be done. Should you include everything but report the quality on the basis that qualitative researchers would say that any qualitative evidence is good evidence? Or should you only include evidence in which you have reasonable confidence? Our team takes the second view. We don't include studies for which we cannot have any, in which we have no confidence at all. So we don't include all those studies, but that is debatable. Summarize them according to the themes, and then assess the confidence in those themes and the quality of the studies that contribute to those themes, the body of the studies that contribute to each of those themes, or in guidelines to speak, the findings, so the evidence findings as opposed to the themes, is how they talk about it in terms of guidelines at WHO. So just as an example of a particular one, this is the first one that we did, the antenatal one. This is the reason why we were asked to look at this. particular topic. We produced 2 reviews that were published separately to the guideline. So the first one was this one. Now, interestingly, one of the things that we keep having to tell ourselves is that when we do these What Matters to Women reviews, we are not actually looking at the provision of antenatal care. And I've looked at this heading again. Actually, it's not correct, because what we do when we look at the What Matters to Women reviews is we look at the phenomenology of the condition. So what is it to be pregnant, as opposed to what is it to have antenatal care? So actually, and we constantly have to remind ourselves that this is what we're looking at when we're looking at these particular reviews. So interesting, looking back at it, that topic isn't quite correct. But anyway, there you go. So this is what I don't need to go into these details, you can see them, the number of studies we found. There was a fairly good mix of countries that we got. By the way, the other thing we do is we always look at almost always, unless it's PhD students who can't do it, but we almost always look at all languages. We don't usually put a language restriction on the basis that usually, at least if you're working with WHO, you can get a translator, or actually Google Translate's quite good, particularly at the abstract stage. Again, interesting for debate, but Google Translate can let you see whether you need to include it as full text at least, which is quite useful. This is what our first tables look like. So again, this is similar to the one that we published in the original study that was picked up by Özge at WHO. So you can see the theme, which is the evidence statement, effectively, the sub-themes, the studies that contributed to those, the quality of each, the study and where the study came from, and the quality score in order against those ones you've got there, and then a comment linked to that. And we summarized all of these findings under this theme, positive pregnancy achievement, which became the theme for these guidelines. The positive experience became the themes for these guidelines as they came through. And this is just a kind of summary of those particular findings about what matters to women. So again, this is not about what they actually received in terms of pregnancy care, antenatal care. This is what matters to them about being pregnant. And what they wanted in terms of being pregnant was a positive experience, which was about maintaining physical and sociocultural normality, whatever that was for them, maintaining a healthy pregnancy, which included, obviously, not dying, clearly, so that the survival element is in there for them and their baby, and morbidity was also in there for them and their baby, and effective transition to positive labour and birth. So these women were not just thinking about being pregnant, they were thinking about this whole phenomenon. And actually, interestingly enough, we're just finishing the postnatal guidelines, and women talk about this transition again in the postnatal evidence that we've got. So there's a kind of a complete loop that's coming out through the antenatal, intrapartum and postnatal guidelines. And and then achieving positive motherhood, again, and that's coming out in the postnatal guidelines. So they were thinking about this at the antenatal stage. So when we think about providing antenatal care, it's not just about, how filling their tummy and doing their blood pressure and doing an ultrasound scan, or in some countries just doing an ultrasound scan, which has become become antenatal care in many countries, just scan and off you go. It's much more about helping women to make that transition. And we kind of hypothesize this in Maslow's hierarchy of needs, which again, many of you will know about, old thing, but the idea being that we tend currently to focus on the bottom end, the safety needs and the physiological needs, and we forget these other needs, which is actually what women are talking about. And in terms of providing care, we need to understand that that is what matters to women at each stage of their journey. We did a Wordle, which is actually in the paper from the data. And from that Wordle, we basically saw 3 chunks of care provision, if you like, that needed to be picked up. So the central one was around support, social support, etc. The next one was around information, which is the one on my right, and then the other one was around clinical care. So that became summarised as these 3 things: support, information, effective clinical care, with high confidence in the findings because they were across a whole range of settings and types of women and so on and so forth. So this evidence was integral to the guideline process, effectively. It became the overarching guideline philosophy. And these are the 3 components that went in. Those other 3 components went in, and these are the 3 kind of conclusions, that the outcomes of pregnancy go far beyond just ANC coverage, skilled birth attendance, etc. There's not much evidence from clinical trials and systematic reviews on what matters. because what happened is that the notion of a positive pregnancy experience became integrated as an outcome into the guideline post hoc. So it wasn't there when the guideline terms of reference were set, but it was integrated into the guidelines, and in the effectiveness reviews that were included, we looked for this outcome, and of course it wasn't there. So that's what point 2 means, that actually most effectiveness guidelines don't include anything other than satisfaction, if they include anything. And satisfaction is a very poor measure for positive experience, actually. So that's another debate we can have another day. And that pregnant women think about this whole phenomena, this whole trajectory, not just the antenatal situation they're in. We then did a couple more reviews that actually were about why, more about why women don't use care. So this wasn't about the phenomenology of being pregnant, it was about why women don't use care. And we did it with women and with staff, and we had a larger number of studies than we did in the first review. And then for the providers, we also had a wide range of studies that came into play. And we had summary statements for both the women and the providers, and a line of argument for both. And this was registered on EPOC and ended up being one review on EPOC. So there's a whole one combined review on EPOC of the outcome. I'm not going to give you the detail that you can look at it yourself, but it was just to say that there were these two components: what matters, which was about the framing, and then what gets in the way, which is about the service itself as it currently is provided. So this is just an example of an evidence statement. So this is about nutrition, the bottom recommendation 1.1. And then this is the acceptability text in the guideline against nutrition that actually puts in some of the qualitative data with the confidence that we had in those findings based on CIRQUAL. And these are some of the outcomes that are in the guideline that actually are about positive experience, that have come about, if you like, as a consequence of weighting the positive experience. They probably would have been there anyway, but they actually were strongly reinforced by what came out of our data. And midwifery-led quantitative care is particularly highlighted there, because that was one of the things that really hit the buttons for all the things that women wanted. You can't see this. This is actually, and clearly, this is one of the logic models that's in the EPOC diagram, and it's based on the theory of planned behaviour. About behaviour, and it basically summarizes behavioural beliefs, normative beliefs, control beliefs, attitudes and norms, and then intentions and what happens, and a feedback loop. So this particular feedback loop is basically saying, I do need to go. I believe in ANC. ANC is important. Other people around me think it's important. If I get complications, I need to go to ANC. I intend to use ANC. I did so once, but I'm not going to do so anymore, because when I got there, it was really difficult to get there. I had to pay money for it, and they treated me really badly. So the control over that fed back into, I'm not going to go again. So this is an example of one of the logic models about women who might attend antenatal care initially but don't return. What are the pieces that come in? And each of the paragraphs of text come directly from the qualitative evidence. So just a summary, it's a good thing. It can work. It can be very useful. And it helps in this case, and in fact the other cases, to identify meaningful outcomes. And in fact, both for the antenatal and to an extent the intrapartum, and I'll come to the intrapartum in a minute, this was post hoc, but now for the postnatal guidelines, we are doing the qualitative review partly to inform, or we have done the qualitative review partly to inform. The What Matters to Women review was done partly to inform the components that are in the effectiveness reviews and the outcomes. So it's a priori as opposed to post hoc. To identify the important interventions, again, that's more so with the postnatal recommendations and the model of care, and the implementation considerations, which I'll come to a bit at the end. And to frame the overarching theme. So as I say, this is a quote from Ban Ki-moon when he was UN Secretary General, around this framing of the total notion of positive pregnancy experience. And this is new for WHO, to actually frame a guideline by experience. And this is the one for intrapartum care for a positive childbirth experience, and the postnatal will be the same. So, this is again, the finding is not so different than it might be than it was for the antenatal, that what women want is both safety and well-being intrapartum. Again, you can see a theme emerging. So, and it's not just saying everything's got to be nice and lovely, but it's saying is, if women need intervention or they want it, they want to keep a sense of personal achievement and control through active decision making. So if they want a cesarean, or if they need a cesarean, for example, that's fine. But, it needs to be still a positive experience for them and their partners and their babies. So this is just a summary of some of the guidelines. There are others that I haven't put in here that we weren't involved in, that have come out over this period of time. And as I say, we're doing the postnatal one now. But they're, this is beginning to be much more mainstream. And these are other QES, so QES specifically, qualitative evidence synthesis outputs that have come, again, I put Andrew's 2001 one there, he may even have an earlier one, I don't know, and then a more recent one that he's been part of here. We are part of this 1, 2, 3, there's the second paper here, but a series of 3 papers around doing QES based on our experience with a range of colleagues, including Tess Lowry and Simon Lewin and Claire Glenton and so on, and Özge from WHO, and then obviously there's a whole Cochrane piece now on qualitative evidence synthesis. So it's becoming growing up, becoming a teenager. So just moving into implementation then, I'm not sure how much time, where are we at with time? Oh, yes, we're all right. So moving into implementation, we might have a bit more time than we thought for discussion actually. I want to use the example here of the guidelines on reducing or optimizing caesarean section, which have been recently published last year, I think. And this is, for those of you who don't know the maternity field, it's a really big concern. Some of this is built on the back of this notion of too much too soon, too little too late, which was a phrase that was coined by Soo Downe and used as one of the, for a Lancet series on maternal health, which basically said we are doing far too few caesareans for some women, well, not just caesareans, inductions of labour and so on and so forth, far too few for some women in impoverished and low resource settings, and far too many for women in other settings. Interestingly, not just that high income countries have too many sections and low income countries don't. I mean, as an example, I was asked to go to Soo Downe by a retired obstetrician who was really concerned, because he said that in their hospitals, so Soo Downe being one of the poorest countries in the world, in their hospitals, they're doing far too many caesareans, and women are dying because they're having caesareans. And in the rural areas, they're doing far too few, and women are dying because they're not having caesareans. This is within country. And it's also true in India, where we've been working recently, where caesarean section rates are heading for 80% in some hospitals, and they're 2% in some rural areas. So, go figure. And the maternal mortality does not necessarily follow what you might expect. So, there's a U-shaped curve with maternal mortality around the rate of inductions. So, in the light of all this, the Lancet did a series on optimizing, I think they called it optimizing caesarean section rather than reducing. And WHO were asked we did a paper for the series, and then for the paper we did a systematic review, a number of reviews, but one particular qualitative systematic review. And the ones that we did in our team was around non-clinical interventions to reduce unnecessary caesarean section. And the conclusion from the series and the guidelines was basically that over 15% caesarean section rates are unlikely to improve outcomes. Some say 19, but 15 to 19, certainly not 80%. And this is a direct quote from the Lancet series: the rise in caesarean section has to be stopped, my emphasis, but still a very strong sentence. So it's not really enough just to produce the guidelines to stick them on the shelf. It never is enough. But in this particular case, it really isn't enough to do that. So Özge, in her wisdom, the marvellous Özge, decided that we had to actually start, and Mercedes, sorry, so this is Anna Pila-Bertrand who did this. So Anna Pila-Bertrand was the lead at WHO on this particular guideline. And in her wisdom, also a very wise woman, she decided that there was a need to get implementation going early. So before the guideline was launched, the WHO team took some of the qualitative evidence to a range of countries. I can't remember exactly which ones. They were Africa and Asia, anyway. And these are pictures from some of those meetings, to look at the data and to say, okay, how would you use these data to implement change? How would we use the qualitative evidence to help us to implement change? Does this evidence mean anything to you? And which pieces of it might be relevant that you might want to build on to implement change if in your local setting, if you want to reduce caesareans. And at the same time, we were separately commissioned to do some work looking at a framework, at a feasibility framework that might be used for any study that wanted to make change happen, where we were asked to go and talk to marginalised women, or we didn't, we asked colleagues of ours to talk to marginalised women in India around a range of so-called modules for implementation. Again, using some of these data. And then there was also a meeting which I was at, which is why I'm particularly highlighting this, and then there were many others, but I'm just highlighting it as a particular anecdotal example, where we met WHO and so Anna Pilar and a range of obstetricians and a midwife, one midwife from these countries, Morocco, Lebanon, Egypt, Syria, and Iran, met in Beirut in 2018, so around about the time the guidelines came out. And it was in this room, although it didn't look this beautiful when we were in it because those tables weren't there, but anyway, to talk about, again, how you might implement the guidelines if they were to come. And we talked about a range of things, including using Robson criteria, which again, those of you who know the field will know what that is. It's a useful clinical and quantitative tool, so not just the qualitative evidence. But we also talked about the qualitative evidence, and we talked about actually the theoretical insights arising from the reviews around the theory of behavioural change specifically, but also around diffusion of innovation and some of those other things that you know, some of those other theories of change that we all, well, many of us know about already. And everybody between them worked on a process of potentially getting these guidelines implemented. And one of the things that I'm particularly going to highlight, two things I'm going to highlight here, that came out spontaneously from the discussion, but also were clearly in the qualitative evidence, was one of the obstetricians said, what we need is happy births. Again, by which he meant, excuse me a minute, births that are as physiological as possible, which is what the women said in the qualitative evidence, but also where they need intervention as positive as possible. Again, what the women said in the qualitative evidence. But what the Iranian team said is that the thing we need to do is to talk to the judges, because the thing that came out really strongly from the qualitative evidence was that the fear of litigation in every country, whether the litigation rate was high or low, the fear of litigation was a major concern for clinicians, for the staff. And they quite clearly said that that is why we do the sections very often. We do it for money, both for the money for us and money for the institution, but we also do it because we're really afraid that if we don't do it, we're going to get sued. And this was such a strong finding in the evidence that we were wanting to suggest that actually talking to lawyers would be a good thing. And in fact, the Iranians had already done it. They'd already started doing that. So it was fascinating to see how the qualitative evidence and the implementation piece began to come together as something that might be an integrated phenomenon. So in summary, this is really just the beginning, I think, and I'm sure many of you on the call have, as I say, a lot of expertise and evidence and knowledge to put into the mix, and our way of doing it is definitely not the only way of doing it. We are still learning as we go along. Every single QES we do, or every single qualitative synthesis we do is different, and you know, every time we think we wish we'd known this last time when we did it. I think that the thing I would perhaps leave with you is two things. One is about the outcomes. So in terms of the intrapartum guideline, what was interesting is we did it similarly to an extent to the antenatal one, whereby the outcomes had already been set, although those outcomes did include positive labour experience, building on the antenatal experience. But what was not in the guidelines initially was anything to do with pain relief, which actually, of course, when we did the What Matters to Women, came out very strongly. Despite what I said to you earlier on about epidurals, women still need some form of support for their labour pain, whether it's a person or whether it's pain relief. And so having come out of the What Matters to Women review we did, the first review we did for the intrapartum guidelines, that was put into the guidelines. And so then a new effectiveness search was done for pain relief, interventions to reduce labour pain. And then for the postnatal one, as I say, we're starting by doing those What Matters to Women reviews before anything. So that's changed. And then the other thing to say, for those of you who are qualitative researchers primarily, we have to really learn the lesson that the things that the outputs you get, the thematic deeply philosophical and theoretical kinds of analyses that you get when you do an in-depth either phenomenological or grounded theory or critical theory or whatever ethnographic qualitative review are not the themes that you need to create for evidence syntheses. They're a different beast, and we had to learn that the hard way. So I'll be interested in discussing that with anybody else who's actually had that experience, because what's needed for a guideline is much more instrumental than what's needed for an in-depth qualitative review or a qualitative analysis. So I think I'm going to stop there. I think we're just about on the 45 minutes or so. Yeah. Should I turn my mic off and see if there's any questions from anybody?
Great, that's fantastic, Sue. Thank you so much for that.